Right. Looks like we're at 12:03. Good afternoon. Thank you for attending our Season 8 premiere of OCHIN Grand Rounds. I am your host, Corbin Caniglio, and today I could not be more excited to welcome Dr. Rachel Gold of OCHIN and Kaiser Permanente Center for Health Research, Dr. Suzanne Morrissey of OCHIN, and Arwen Bunce of OCHIN as they present on the final results of the ASCEND study. Dr. Rachel Gold is an epidemiologist, health services researcher. Her work focuses on using health information technology to improve care quality in public clinics and the implementation methods needed to support adoption of such technologies. Dr. Gold has partnered with OCHIN Practice-Based Research Network since 2005. She now has a joint appointment at the Center for Health Research, where she is a senior investigator, and OCHIN, where she is the lead research scientist. Dr. Suzanne Morrissey is an academic and applied medical anthropologist. As an associate professor of anthropology and interdisciplinary studies at Whitman College for over a decade, she taught courses in critical medical anthropology, cross-culture health systems, and integrative medicine, qualitative methods, and urban studies while advising students toward future careers of their own in healthcare and public health. Since becoming a research scientist at OCHIN, she has been involved in numerous projects at the intersection of health, IT, social medicine, and health disparities. Arwen Bunce is a medical anthropologist and founder and scientific lead of the OCHIN Qualitative Core for Iterative Research and Design, OARS. Ms. Bunce has a particular interest in the application of rigorous and innovative qualitative research methods to the study of health and healthcare systems, with her current research emphasis on the intersection of social risk-informed care and health information technology. This session is being recorded. Attendees are muted upon entry, but if you are not, please mute your microphone and pose your questions through the Q&A or chat box. This presentation will last approximately 45 minutes, with 10 to 15 minutes at the end to answer any questions you may have. We will now pass the mic to Dr. Gold, Dr. Morrissey, and Ms. Bunce for final results of the ASCEND study on social risk screening implementation in community clinics. Dr. Gold, it's over to you.
Thanks. I'm going to share my screen and we're going to let her rip. Okay, it just takes a second. Okay, are you seeing my slides, Corbin?
Yes, I can.
Okay, I'm going to get going. Just quick note, this was funded by, this study was funded by NIH, specifically the National Institute of Diabetes, Digestive, and Kidney Diseases. I first want to just thank the amazing team from Kaiser Permanente, OCHIN, and OHSU that helped make this happen. This just was quite a team effort, and it was a lot of work, and I would love to spend time singing the praises of every single person who's named here, because we couldn't have done it without each and every one of this great team. Okay, so the study ASCEND, which we love our tortured acronym, stands for Approaches to CHC Implementation of Social Determinants of Health Data Collection and Action, had three overarching aims. The first was to formatively evaluate how social determinants of health data collection was happening across OCHIN member clinics. The second was to test an intervention to see how effectively it helped increase social risk screening. We call that the SDH action plan. And the third was to then do a realist evaluation of whether and how that intervention improved social determinants data collection and also diabetes risk management. Although I don't think we're going to talk about the diabetes results today. Okay, so really briefly, I'm going to talk about study aim 1, because quite frankly, they're a little out of date now, as you'll see. This was also research that we did that was 2016 to 2018. And what I love about this slide, though, is this shows you how, when we first got started, we first turned on the social determinants documentation tools in OCHIN Epic. There was this wonderful increase in our cumulative number of screenings that we were so excited when it got to like 5,000 or 37,000 screenings that had happened. We're now over 2 million as of this month. So this is just the beginning of something that was really much bigger. But once in the 5 years ago, this was still quite exciting to see this many social risk screenings taking place. And just quickly, I use the term social risk instead of social determinants of health, but they really they basically mean the same thing. The other thing that I think is really, here's another interesting result. This is, again, just from those first couple of years, but what you see here is this. For each of these bars, the blue column, each bar indicates all patients who were screened for any social risk. The blue part of the column is folks who weren't, we don't think they were actually screened. Then the folks above the zero there are folks who were screened. And so the way to interpret, I'm going to focus it on this, is this. The gray box is of the folks who were screened, who screened positive, and the orange is of the folks who were screened who didn't. So just a way to think about this is the first one, FRS stands for financial resource strain. Of the folks who were asked, do you have financial resource strain? Half of them said, yes, I do. So while it says it's 16%, it's actually 50% of all the folks who were screened for social risks. So again, with food insecurity, it's about 30% of the folks who were screened had it, et cetera. So you can just get a sense of the distribution of reported social risks by domain. Again, these data are from our first name and are now fairly out of date. So I'm not going to spend too much time on them, but we did do a little qualitative research in the first aim to just understand, well, what were the things that were motivating and supportive of clinics being able to start doing social risk screening. And we identified a couple of really big pieces, which kind of are, one of them is sort of like, yeah, no kidding. One is external motivators, which is if there was some kind of a requirement, some kind of a grant or certification requirement or some kind of a payment model that required folks to do it, that was quite incentivizing, like no kidding. For example, the grant program to improve care for homeless patients who require clinics to screen for social risk. Well, then that clinic's going to do that screening. And then the other was, and again, maybe obvious, but not as much so, is that if there was an advocate at the clinic, someone who was really advocating for this kind of screening to take place, and that was also a really important facilitating component. So for example, at one clinic, there was a quality improvement coordinator who developed a whole data collection blueprint in partnership with their accountable care organization manager. At another clinic, they were really trying to improve how primary care and behavioral health folks communicated. So the head of behavioral health really promoted social risk screening among their staff. Okay, so this is the work we did kind of as background to start to get us ready to conduct the actual trial, which was our second aim. Here's a little bit of a background to how we thought about the work we were doing, right? Social risks, again, otherwise called adverse social determinants of health. We know that they drive patients' risk of chronic diseases. And in case this isn't obvious, I suppose I should have made this more clear, but when we talk about social risks, nope, we're talking about food stuff such as food insecurity, housing insecurity, utilities insecurity, transportation instability, financial instability. There's quite a few more, but that's enough. I mean, you get the gist. So we know that these kind of factors make it hard for folks to increase the risk of chronic diseases like diabetes, and because they make it hard for folks to engage in the behaviors that minimize the risk of that. And then once folks have something like diabetes, they make it harder for folks to self-manage those diseases. This is very clearly shown in the literature. So if clinic teams want to try and help mitigate those impacts, like for example, by making, let's say, referrals to transportation services or something like that, they need to know what patients' risks are. Like, no kidding, right? So there's a lot of national initiatives over the last 5 or 6 years that have been really recommending everyone do this kind of screening. And we were right at the very cutting edge of trying to figure out how to help make this happen. So there are a lot of community health centers or similar, FQs, et cetera, who have been doing social risk screening kind of forever, but not necessarily doing it in a way that was documented, not necessarily doing it in a way that was systematic. And many clinics found it difficult to sustain that process or expand it. And again, or to do it in a way that was kind of sort of very systematic and documented. So those challenges have made it limited how feasible it is to document social risk information and use that information to improve health in the populations that we all serve. A number of barriers to this implementation and sustainment have been identified, and I'm showing you here this National Academies report that really summarized in one of its chapters a number of what these barriers can be. I don't know why this guy keeps skipping, but I'm just the technology is doing what it wants. So clearly evidence was needed on how to help clinics implement and sustain these kind of screenings and social risk screening and social risk referral making. So we tested whether this implementation support intervention improved those outcomes. We also looked, because we're funded by the Diabetes Institute, we also looked to see if there was an improvement in diabetes outcomes. We believe, and I'm pretty, at this point, it's really just obviously true that this was the first trial conducted of a multi-component implementation intervention to target these outcomes in any setting. Here's the intervention. So this is what I want to show you. This is you'll see that this is a high level overview of what we provided to study clinics. And if anyone who is listening right now, who is on one of our study clinics, took part in the study, I thank you again. We can't thank you enough for, gosh darn it, for your ability, for your jumping in and being willing to be part of this. So I just want to show you here that we had 5 overarching steps. This 6-step process. First step is create a social determinants team. Second step is identify your goals for social risk screening. Third is create a social determinants plan or a workflow. Step 4 is train your staff. Here's our plan. Step 5 is to roll out and then iteratively revise your workflow to get it to work. We walked our study clinics through this over a 6-month period. We provided technical assistance in using relevant EHR tools, which are specifically relevant to identifying clinic goals and then having a workflow. I mean, these tools, again, are where are you going to document it? How are you going to review it in the EHR? Do you want to, there's a lot of different EHR tools that folks could use to support this process. We had the most amazing practice coach and EHR training team. I just want to call out Meg Bowen and Julianne Baba, and Romer as well, who were just so integral to making this work. The clinics really liked working with them, and as did the study team, of course. Okay, so our wonderful team would walk the clinics through this process, through this 6-step process. They would meet with clinic leaders a couple times a month, and then we provided for each of these steps. We provide all kinds of guidance about how to do it. How do you train the staff and orient it? How do you identify your goals? How do you engage leaders? How do you develop workflows? We provided help for each of the steps. We provide a certain amount of peer-to-peer learning so that clinics that were taking part at the same time could work with each other, and we provided monthly feedback data, and that was the intervention. The trial design, I'll go through fairly quickly, but it's what we call a stepped wedge design. So although there were 31 clinics took part, we worked with 4 to 6 at a time. I'll note that wedge 4 began in February 2020. That should make all of you go, oh, gosh, dang it. That should make all of you go like, oh yeah, your study happened. COVID happened in the middle of our study. So you do need to interpret all the results with that in mind. It definitely was disruptive. We looked at clinics 6 months pre-intervention, 6-month intervention period, and then for at least 6 months post-intervention. And again, what we looked at was clinic monthly rates of social risk screening and making related referrals. And we compared clinics that had versus hadn't yet had the intervention. That's how the study design worked. Okay, so remember I said there were these 5 steps. Here they are again. Just that we found of the 31 clinics that first signed up, about 5 withdrew from the study. Most of those were because COVID made it just so they couldn't really do their thing. 7 fully completed all 5 steps. 12 fully or partially completed all 5 steps, and 7 of them got to the last step but kind of skipped a step, which worked out okay. So this is it's a little bit small. I hope you guys can see it, but this is a cool way of visually showing how each of the clinics, how each of the wedges did. So here's wedge 1, wedge 2. Each of these is a group of clinics. Oh, for Pete's sake! And the dotted line in the middle, that's when COVID happened. The solid line is when the clinics started their intervention, when we started working with them. So here's the straight. Here's when we started working with clinic 1 or the wedge 1 clinics, and they, we worked with them for about 12 months. And you see, for example, in this first wedge that after, a little bit after our 6-month period, you do see a few of the clinics really start to kick it up. But again, you can see that there's really quite a lot of variation here. I mean, that's really what I want. The take home here is that, like, while there was some improvement in clinics doing screening, it is a lot of variety in what we saw as an outcome. So we published these results, earlier this year, which was super exciting. And the trial results, in broadly speaking, was this, right? So we were asking again, did this 6 months of support improve adoption of social risk activities? Well, what we found was that during that 6-month period, when we were working with the clinics, their social risk screening rates were 2.5 times higher than in the pre-intervention period. That was a significant difference, really exciting. But that impact was not sustained post-intervention. So once we weren't working with the clinics anymore, folks just kind of, for overall, the screening levels petered out again. Again, consider that the pandemic was part of this, but nevertheless, that's our main finding. And we didn't see any difference in referral rates. And I'm going to talk to you now about kind of a bit about like, well, what does this mean? Did the intervention not adequately address the barriers to sustained implementation? Was 6 months not enough to really bake in this practice? And overall, well, we'll get to this in a second. I'll talk about those implications. I just want to show you these results in a different way again, just so for those of you who prefer to see it this way. There's, again, this is the bolded line is, the bolded text shows you that it's statistically significant. But oh, for gosh sake, that there was a again, you see here, it's about 2.5 times more higher screening rate than pre-intervention, but in the post-intervention period, while it trends in that direction, it was not a significant difference, and there's no significant difference in referrals, regardless of whether patients did or did not document a need. So what does this mean? Well, it means that intensive and adaptive implementation support, which is what we provided, is effective at temporarily increasing social risk screening. Are these results conservative? Like would they have been, were the rates lower than they would have been had the pandemic not hit? Maybe not. Where most sites targeted a subset of patients, and so we weren't really able to account for that in our analysis. So the changes we see here may have in fact indicate more success in meeting goals than they indicate, or than they look like, excuse me. And again, because CHCs, as we know, have this wonderful history of providing this kind of contextualized care, the intervention might help improve these efforts, but maybe doesn't necessarily lead to some kind of outcome that one can measure. It just may be that they're happier with the way they're doing what they're already doing, and maybe that the increases didn't have that much to do with what we provided at all. There may just be a secular trend in this going on. And we did try and account for that, but it's certainly possible. So the reason we had the impact we had, we think, is because all the ways that we tried to support the intervention have been proven effective in other contexts. So we expected them to have it that work here, and so they did. You have a good practice coach and a good EHR trainer, it's going to make a difference. It's possible that the intervention didn't address the key barriers, as I said. It could be that there just wasn't enough time, or maybe the reason we did have an impact is because just engaging with someone providing outside support is a motivator to be implementing this kind of change. And when that's gone away, like, okay, now I've got some other fires to put out and I'm dealing with that. Again, I strongly suspect the intervention period was not long enough. But I think all of you know that, like, for clinics to have a staff member engage in any kind of activity other than just care provision for more than 6 months, like, that's a big ask. So there's a bit of a tension there. Like, how do we, if it turns out it takes a year of support, like, can clinics really provide, have someone who's working with outside folks for a year? Like, maybe, but it's a big ask. I think the really important piece here, the thing that we really emphasized in our paper, was, what are the resources that CHCs need to implement and sustain social risk screening? And this is really important, as Medicaid policies are starting to require in some states that folks document that they did this. Well, if you're required to do it, and it's really hard to do without a whole lot of support, like where Medicaid is setting us up to struggle, let me say that. That's the point we made in the paper, and we hope that the people who make decisions about this kind of stuff would pay attention to it. Basically, again, for the conclusions here, it's hard for folks to implement this kind of screening. Substantial and ongoing support may be needed. We did create an implementation guide, which there's a screenshot here of that. And we did, and that guide is available online. If, for those of you who are OCHIN members, it's in Ella. There's a version of it that's actually quite OCHIN focused. And if you're not an OCHIN member, there's a publicly facing kind of EHR agnostic one available at the Siren website. We can get that to you. Now I'm going to hand it over to my colleagues, Arwen and Suzanne, so I can talk about the realist informed evaluation that they conducted to try and really understand these results better than you can just from looking at the numbers. So Arwen and Suzanne, I will hand it to you. And I will try to keep the slides from skipping forward as they are.
Yeah.
I don't know why.
Thanks, Rachel. I'll start us off and just talk about first, as you see, it's highlighted. Aim 3 represents the realist-informed evaluation that explored the mechanisms through which this tailored coaching and technical training intervention could impact social risk screening uptake in 26 OCHIN member clinics. So we'll elaborate on the method shortly, but by way of introduction, evaluation data sources included the documented content of interactions between the clinics and the implementation support team, as well as EHR data. So analysis was composed of iterative cycles, of which Arwen's going to talk about more fully, but iterative cycles of developing, testing, and refining program theories about how the interventions did or didn't work, for whom, and under what circumstances. Then normalization process theory was applied to the realist program theories that we were developing to frame and enhance our understanding of the results. Next slide, Rachel. Oh, or no, back one. Sorry. Yeah. So some of you are aware of what realism is, a realist evaluation approach, but we'll give you a high overview of it for those who are less familiar. Realism is a philosophy of science that is theory-driven and situates itself between positivism and constructivism. And it's about using theory to understand reality when that reality is assumed to exist beyond and independent of our knowledge and beliefs. So evaluation to a realist should occur in a space between what's directly knowable and what people believe reality to be. And in turn, evaluators come to rest on program theories that represent a correspondence between a claim about the world and the world itself. Realist evaluation then is a way to get beyond simply assessing whether an intervention worked or didn't work. In this kind of evaluation, we ask how and why a program does or does not work, for whom, and under what circumstances. So the approach involves this interactive decision-making process among the researchers in which they toggle back and forth between data and hunches about program successes and failures. Next slide, Rachel. Thanks. So in a realist world, interventions themselves are seen as theories in action, whereby program outcomes are caused by the activation of mechanisms within certain contexts. And you'll hear us talk about context and mechanisms as being really central to thinking about outcomes in intervention research. So in other words, to make sense of why interventions take hold, multiple and variable theories are actually tried on to explain the complex interactions of the context in which an intervention is happening, the program features of the intervention, and the social actors who are involved in actually making things come to life. So the theories, as I mentioned earlier, will approximate reality. And these theories are approximations because out of the infinite contextual factors that may affect why an intervention does or doesn't work, only some will rise to explanatory value. And we think about that value in terms of generating useful knowledge and transferable lessons on how to roll out, scale up, or implement elsewhere. Next slide, Rachel. The realist approach is inherently mixed methods, as it advocates the use of varied data sources and perspectives to gain a nuanced and balanced understanding of the complex interaction of context, program features, and actors, as I mentioned before. So we liken the process to being a detective who goes from that which is concrete. So we're looking at what's observable. Arwen and I are qualitative researchers, and all the people who came before me working on the Ascend project, working with Arwen, looked at the observable to then establish causal links through understanding underlying social structures and mechanisms of change. So really wanting to get a sense of what's happening in the culture of the clinics that are going to affect whether or not things take hold. So according to critical realist Ian Hottie, the movement towards these explanations involves a theory building process you keep hearing me talk about theory, whereby the realist researcher begins with the experienced results of something, such as a social problem, and then works backwards to explain why it is the case or what must have caused it to happen. So this mode of inference is referred to as abduction or retroduction, and involves abstracting from empirical data about our concrete phenomenon while drawing on insights from pre-existing knowledge and experiences of the same phenomenon elsewhere. So with that, it's pretty appropriate that I turn it over to Arwen to explain what these abstract ideas mean in terms of what we saw on the ground, because it's also Arwen and Rachel's and the other people who were so deeply involved in the project. Their experiences in a realist approach are part of how you do your analysis. You don't try to do your analysis without your previous understandings of things you've learned. So I'll turn it over to Rachel, or sorry, over to Arwen.
All right, thanks, Suzanne. So like Suzanne said, I'm just going to sort of dive into how we applied this approach and what we found in the ASCEND study. And this slide is just a reminder, this is what Rachel was talking about. The SDH action plan were the implementation strategies that we used in the ASCEND study. So it's this 5-step process. And so this implementation support is what we were trying to figure out, sort of Suzanne was talking about the realist approach, how and why, for whom, and under what circumstances this 5-step process helped clinics start and sustain systematic social risk screening. Next slide, please. Thanks. So we were really trying hard not to overburden the clinics, even pre-COVID. So we chose to use, most of our data was based on interactions that the clinics were already having with the implementation support study team. So this meant we had transcripts from, and then observations and field notes from implementation support interactions with the clinics. This totaled 211 different documents. We had emails between the clinics and the implementation support team, because the implementation support team was very, very responsive to questions and needs during the study when they were working with the clinics. There was a lot of back and forth, so we had that. And then at the end of each wedge, like Rachel explained, we had sort of 5 to 6 clinics, 4 to 6 maybe in each wedge. And at the end of that, we did sort of a debrief interview with the implementation support team just to get their ideas sort of about what was going on. And then in terms of analysis, so we first created clinic summaries for each separate clinic based on these realist concepts that Suzanne was referencing. We had it sort of divided by this context, mechanism, and outcome. So this was sort of the start of the iterative analysis process. And then once we finished implementation support with all of the clinics, then Suzanne and I really sort of dug deep into these clinic summaries and spent a lot of time reviewing and discussing them and talking about what we were seeing and what patterns were across clinics. And through this process, we identified the mechanisms through which these implementation strategies, again, made a difference, created change. And then we took those ideas about mechanisms and our sort of initial explanatory theories about how things worked, and we went back to the raw data, those transcripts and emails and field notes, to really test and refine these theories through these sort of iterative cycles of engaging with that raw data. Again, with the ultimate goal of getting to these explanatory theories that explained, you'll hear us say this a lot, why and how the intervention worked as it did, for whom, and in what circumstances. Next slide, please, Rach. Okay, so now I'm going to get into sort of what we came up with from the data for these theories. So the first one we called paradigm. And this is really related to the environment within which this intervention played out that then impacted sort of how it played out. And again, just a reminder that this is all based on the data that we had. So the theory here goes that CHC providers and staff see good care as patient-centered. And so when this SDH or social risk screening is seen as promoting patient connection, and then pragmatically where the workflow and resourcing make it possible, then social risk screening and data is seen as adding value, and staff feel it is worth the effort to collect and use this SDH data in care. And we saw it on both sides, right? Within a single clinic, you would see providers and care team members who either saw the screening as facilitating or interfering with patient connection. And it often came down to sort of where they fell in these three buckets. So often it was the clinic screening approach, whether they were doing this synchronously in conversation or asynchronously, say through my chart or maybe filling things out in the waiting room, whether it was seen as a more conversation versus kind of a more formal ask exactly as written and click the boxes, whether there was this emphasis on data collection versus relationship. Another piece that fed into this was expectations for use of the SDH data. I mean, most of you probably know, you can use the social risk data in many ways to make referrals to community organizations, to adjust care in the moment, sort of for advocacy or policy, or also just to sort of know more about each other and sort of improve that doctor-patient relationship. And then there's also, messaging from leadership about why the clinics were choosing to do this and put time into it was also important. Next, please. So the next theory is really about relationships. And some of this is, again, kind of like Rachel was saying about the others, is a little bit obvious, but it really was it played out very clearly in terms of how uptake sort of happened and how well it's sustained. So when you have positive, respectful relationships, then staff feel empowered and supported to experiment with workflows. And this then fosters an environment in which staff feel, safe enough to try different things and engaged enough to try different workflows, which then leads to workflows appropriately tailored to specific settings, which means that then they're more likely to be used. And we really saw this play out at 3 different levels in Ascend. So I'm going to echo Rachel's kudos about the amazing team of Meg Bowen and Julianne Bava. Many of you probably know them. But we heard very clearly that their rapport between the two of them was really key to sort of creating this space when they worked with the clinics, where they felt like, oh, this is kind of fun and this is a place I want to be, and therefore we can all work together on this. The second level was between the implementation support team. I agree, Molly. I see your thing about Meg and Julianne. So it was between the implementation support team and the clinic champions. So we heard consistently that Meg and Julianne and the others that were, sort of popping in and out as part of the implementation support team were unfailingly respectful, non-judgmental, and helpful. That was kind of across the board. But there was, sometimes you just hit it off differently with different groups of people, or you have pre-existing relationships. And it was really interesting how you could see that sort of different tenor of those relationships play out in terms of sort of clinic uptake of the interventions. And then the third level was between clinic champions and clinic staff. We let the clinics choose who their clinic champion was. This is a pragmatic trial. And so what we found was that, whether the champion, their standing in the clinics or their social capital, how much they were trusted, it didn't even necessarily matter whether they were higher up in the sort of official hierarchy, but if they had cred basically in the clinic, it made a really big difference in how things went. Next, please, Rachel. Okay, so the next two and the last 2 theories are really related to specific tools that the team developed as part of the implementation support package. And the first one is this workbook. So the workbooks were originally conceived as sort of an organizing tool to guide the clinic champions in sort of this linear step-by-step. These are the decisions you need to make to move to the next step in order to sort of get social risk screening up and going at your clinic. But we heard very clearly and very early on that the workbooks were really facilitating collaboration, that was important. So the theory here goes that the workbooks ground the discussion in a purposeful way, which creates a shared sense of purpose and direction among staff with very different clinic roles and perspectives. Then through that collaboration, staff engage with the ideas, sort of work on this collaborative decision making around goals and processes, and that this really sets the stage for implementation and hopefully sustainment of social risk screening. And I'm not going to read the quotes, but you can see a couple of the quotes there. And as before, only some of the clinics used the workbooks in this way. And when we went back and tried to figure out like who did and who didn't and why, the clinics that did tended to have a pre-existing culture of sort of this cooperative decision-making, workflow development. The clinics did not fall into 2 buckets. One bucket was clinics that had a champion with enough authority and buy-in to just kind of move the work forward on their own, which has some positives because they could just move stuff through, but it led to less collaboration, which had some potentially negative downstream effects. And in other clinics, STH screening, frankly, just wasn't seen as enough a priority. And so leadership didn't sort of give people the time to do that collaborative sort of working through things that seemed so helpful for other clinics. And next slide, please. Okay. So in the last theory that I'm going to go into then, So I don't think Rachel talked about this specifically, but at the end of each wedge, we did something that we called the SDH summary. This is, again, Meg and Julianne really put this together. But what it is a clinic-specific document that detailed the decisions and plans that they had gone through and gotten to through those 6 months of implementation support. And it was on paper, and I think at one point they actually had a place for like clinic leadership to sort of sign off on it, trying to make it sort of very official. So what we found is that this SDH summary provided really tangible evidence of progress and ongoing work for leadership in these clinics. And that instilled confidence in the clinic leaders that the process that they were sort of allowing people to dedicate time to was really going to result in meaningful change, which led to continued support, attention, dedicated time and resources. And again, I'm not going to read these quotes here, but another thing that, we had another quote that's not on here where somebody was like, we did so much work, but it was all in conversation, because that's what this work is relationship building and conversation, but then you couldn't prove anything. And so having this thing where we could take and say, no, look, we did it, it's documented here, was really, really helpful and allowed them to continue to have resourcing to keep this work. And again, as I keep saying, not every clinic that we worked with used the SDH summary in this way. The ones that did tended to have leaders that were paying attention, right? And so cared. And so the clinic champions felt like it made sense to sort of bring this tangible SDH summary to them to sort of show that what their investment was getting them, basically. Okay, I think I'm handing it back to Suzanne now.
Thanks, Arwen. I'll just say that, as Arwen and I have been already saying, the goal of a realist evaluation is to uncover the causal links that we've explained in realist terms are known as mechanisms. And so these causal links between an intervention, and here we're talking about the 5-step tailored implementation, support intervention, so well described by my colleagues, and an outcome, for instance, uptake of patient social risk screening within a discrete context. Mechanisms, the often invisible forces, powers, processes, or interactions that lead to or inhibit change, are activated or repressed by pre-existing and unfolding conditions of intervention settings. So also, as we mentioned in the beginning, COVID cannot be denied as being a condition that was unfolding for many of the clinics. So we put the quantitative data, which revealed ultimately these unsustained results, in conversation with qualitative data, which revealed that some of the implementation strategies, especially those around relationship building, as Arwen was able to explain fully before, that the strategies were effective in those conditions. So once the realist theories were established and the intervention's effect on screening rates was confirmed, we applied the normalization process concepts to the results we were seeing to frame our analysis and to help us understand what we were finding and to enhance the explanatory power of our findings. So I'm going to talk a little bit about how we brought in normalization process theory, if you wouldn't mind. Yeah, thanks. Excuse me. Thanks, Rachel. So normalization process theory is a middle range theory, right? A testable theory that's applicable to empirical investigation. Excuse me, 1 second. That lozenge I had before the talk isn't holding for me. Anyway, it's a middle range theory that frames understanding of an intervention's material practices. So what are people doing and saying as they're actually interacting with the intervention? The aim of MPT is to identify if and why an intervention took hold according to the constructs that are listed here on the slide. So while realist evaluation emphasizes generative mechanisms, as we were talking about earlier, we turn to the MPT implementation mechanism constructs to actually organize our analysis. MPT theorizes that all implementation constructs, all 4 of these, must be effectively addressed and enacted to ultimately attain normalization or routinization of practice. And in so doing, provides a framework to understand why some practices are implemented and sustained while others are not, because maybe not all 4 of these are actually happening under all conditions. So what we found was that the constructs, those first 2 constructs of coherence and cognitive participation, emerged as particularly pertinent to our understanding of the realist program theories that we were developing. So coherence, as we say here, sense making. It's about whether people individually and collectively agree about the purpose of the intervention, their role in it, and the value of it. And then cognitive participation is this relational work. Do people work together to create networks of participation and communities of practice around the intervention? So NPT helped reconcile, the realist program theories that we were developing and trial outcomes, and elucidated why the statistically significant increase in social risk screening rates during the intervention period was not sustained post-intervention. Although, as demonstrated in the program theories, many of the implementation support strategies were effective in many situations, the intervention as implemented fell more toward planning workflows than operationalizing and appraising them. And in NPT terms, the implementation support addressed coherence and cognitive participation, but did not move clinics to collective action and reflexive monitoring. And as I said before, under this theory, all 4 should be in place for a practice to become fully embedded, normalized, sustained in a given setting. Thus, it's possible that the strategies were appropriate, but needed more time to take hold. 6 months is, as we mentioned before, a relatively short period to expect change in a busy health center with multiple priority projects happening. So we have some other theories along with those, and can talk about those more fully in the Q&A. We could save those for another time. But what I want to do is, if you won't mind, Rachel, putting up the next slide, to just say that, and we're going to start a long list of talking about the results that are being disseminated from this project. And most recently, a revise and resubmit that Arwen is receiving for a paper we're putting together for Frontiers in Health Services. So I'll turn it back over to you, Rachel, to talk about more.
Yeah. Thanks, guys.
Yeah.
So I'm just going to spend a few more minutes telling you about the other work we did in this study. So because the nice thing was that we, yes, look at that. Because we just had an amazing team, we were really, really productive in terms of what we were able to publish and the analyses we did. I'm just going to highlight, I'm showing you this honestly just to show off for a minute, because like most studies don't pound out this many papers, and we were pretty pleased with ourselves. But I'm just going to talk about really briefly about a few of the analyses that we did. Some of this was made feasible because we had a couple of PhD candidates or postdocs who worked with us. This one was one of those. We had a PhD candidate in our who worked with our team for a while, Amber Haley, who helped us develop a whole method for how to track the way we adapted the strategies we were using to support the clinics. There hadn't been really a method for that out there, and she helped us develop one. We did a study where we just said, well, let's just look at what's going on with social determinants and diabetes, care quality and outcomes. And this is such an interesting study, I thought, for our analysis. We said, well, can care quality overcome how social risks impact health outcomes of diabetes? And what we found was that patients with transportation and housing insecurity were less likely to be up to date on LDL screening only, but they were just as equally up to date on all other kinds of clinical care quality measures for diabetes, a whole mess of other measures. So mostly the fact that someone had a social risk didn't really make a difference for their care quality. But even among those who had up-to-date care, food insecurity was associated with lower rates of controlled A1C, transportation with lower rates of controlled A1C and blood pressure and LDL among those who had a risk versus no reported risk. So this is a fascinating implication, which is that basically like CHD patients are getting great quality care, equal quality care, regardless of whether or not they have social risks. But even if they're up to date on care, the social risks are still going to impact their diabetes outcomes. This has really important policy implications for what we ask of our clinics in terms of the measures of care quality that we hold them to. Another analysis we did, this was in partnership with Christina Hubner-Torres, who's from Caring Health Center, one of our member clinics. She was a partner on this project as well. She led an analysis which just said, well, can we just look at whether there is equity in who is doing social risk screening, who's being screened, and what the outcomes are by race, ethnicity, and language, because no one had looked at this before. Is social risk screening equitable across these factors? And what we found that about 30% of our health centers are doing any screening. About 11% of eligible patients had been screened. Now that number is actually higher now across OCHIN. All these analyses are data that were a couple years old now, because it takes a while to get stuff published. But we did find that screening and reported needs varied significantly by race, ethnicity, and language. So Black Hispanic and Black non-Hispanic patients twice as likely to be screened. Hispanic white patients substantially less likely to be screened than white patients. Hispanic Black patients were 87% less likely to report social risks compared to white patients. These are some really interesting findings, and the implications are that there's differences in how those folks are being screened, and inequitable screening is something we're really gonna have to pay attention to, because it could undermine the fact that we are trying to conduct social risk screening as a tool for health equity. With another postdoc, this was conducted, Cassandra Nguyen did an analysis that said, well, can we just look at how often folks were screening for food insecurity at telehealth visits versus in-person visits during COVID? What happens during telehealth encounters? And in brief, we found the food insecurity screening was substantially higher at in-person than telehealth encounters, even more so after COVID vaccines became available compared to before. And overall, the food insecurity screening rates are pretty low, and even lower in telehealth visits. So some clear sort of next steps could be inferred from that. And then Arwen led this paper on how patient-reported social risks are used by providers at the point of care. So we did what she and Mary Mindorf came up with, a super cool method for surveying providers, basically like directly through the EHR, using what was very cool. And the question was how are providers using this information at the point of care? Providers said that social risks did influence the care they provided at about a third of surveyed encounters. That's a lot. They found this information was they found it through talking to the patients, or prior knowledge about the patient, or what was documented in the EHR. She found the social risks were more likely to influence care among male and non-English speaking patients, which is interesting, and those who had data in the EHR, which was nice to hear. And the implications here are that having social risk data in the EHR can help clinicians know about what's going on and use it in care planning. This hadn't been reported really before, so this is a really cool paper. All right, that was quite a grand rounds.
Yes, it was. What a great way to start off season 8. Thank you, Dr. Gold, Dr. Morrissey, and Ms. Bunce, for kicking off our 8th season of OCHIN Grand Rounds with that fantastic presentation. And thank you to everyone who attended today's session. Please be sure to follow OCHIN on Instagram at OCHIN Network, all one word, and over on LinkedIn. In addition, head over to ochin.org and advancecollaborative.org to read the latest on our research studies and upcoming events. And don't forget to visit our OCHIN YouTube channel to catch up on past Grand Rounds presentations. And OCHIN Grand Rounds will be taking just a short break for the month of October, and we'll be back on November 16th with Dr. Jennifer DeVoe and Anna Bloom presenting on the AIRS study, helping generations identify risks to health. Invitations to this presentation will be sent 2 weeks prior to the event, but if you are not on our mailing list and are interested in attending this or any future event, please email us at grandrounds, all one word, at ochin.org. That's grandrounds@ochin.org. So, and I'm excited for this last part because I get to say William's famous catchphrase. So from all of us at OCHIN and Dr. Gold, Dr. Morrissey, and Ms. Bunce, and to all of you, have a wonderful rest of your day and stay healthy out there. Thank you, everyone.
Thanks, everybody.